All right, good evening, everyone, and thank you so much for joining us this evening. My name is Sandra Brackle with Dominican Hospital, and I'll be your facilitator this afternoon. Tonight, we have a great presentation by our accomplished speaker, Dr. Anne Marie Jackson, that will be talking about managing menopausal symptoms. Very exciting stuff. So before I go ahead and introduce her, I wanted just to go over a few things. First, this is a webinar, so all attendees have been muted. We will hold a Q&A session at the end of Dr. Jackson's presentation. So please do get your questions ready for her. I know you have a lot of them. And throughout her presentation, please do type them in the Q&A feature at the bottom or the top of your screen. There's a Q&A button. Just go ahead and start typing your questions there, and I will be reading them off after her presentation. And also, too, we are recording this, as you know, so for our Wellness Center library. I will go ahead and send out the link to everybody tomorrow if you would like to recap on anything that she goes over, or possibly you want to send it to a friend or family member going through menopause. So I will send that out to you again tomorrow. So without further ado, I'd like to introduce Dr. Anne Marie Jackson. Thank you so much for taking the time to be out of your busy schedule with us. Dr. Jackson is a Harvard-educated physician, surgeon, and a servant leader. She's a professional committed to improving patient care and moving the needle forward on quality and patient initiatives. As the Women's Service Line Leader and Dignity Health OB/GYN Department Chair, she is recognized for advancing healthcare for women in Santa Cruz County. Her expertise include mentoring new physicians in our community, advocating for excellence, and serving as an ambassador and physician leader for Dominican Hospital in our community. Thank you, Dr. Jackson, for being here. Like I mentioned, and go ahead and you can take over the screen now and start with your part of the presentation.
Thank you, Sandra. Thank you so much. And I really appreciate everybody who's here. I can't see any of you. Maybe that's good. Otherwise, I'd have to imagine, you're all in your underwear, so I didn't get nervous. Haha. I'm going to try to do the slideshow thing here. All right. Very good. So, and then I'll minimize this little box over here so that I don't get that in my way. Hopefully everybody can see the screen and can hear me okay. The title of my talk is Thriving Through Menopause, because of course, you don't want to just get through it and survive it. You want to do well. And hopefully I'll be able to give you a few tips about that. Honestly, when I was asked to give this talk, I thought, are we going to sit down for a week and talk about this? Because it's pretty darn hard to pack everything into an hour. So I'll try to give you a high level overview and at least, be available to answer some questions and then give you some food for thought. But it's by no means going to be comprehensive. I apologize. So whenever I talk with patients about menopause, the very first thing that I do is we talk about changes in our bodies. So just like this person who's depicted here that's gone from a baby to an older woman, our bodies change a lot in that time. Clearly we grow, but also just the way that our bodies look, the way that our bodies function, change. So it's important when it comes to menopause to put it in the context of what's normal, what's aging, what's menopause itself, which of course is a part of aging, but a particularly problematic part. And many people, like, if they feel like they've never looked or felt like this before. And so they're just really at wit's end. A lot of people, not everyone, but hopefully by the end of this talk, I'll be able to help you all with feeling like one of my patients who told me that going through menopause made her feel like she was 10 again, which I thought was sweet. So every time that I try to put a positive spin on it, that's kind of how I frame it. It's, you get to be 10 again before you ever had your periods control your life. So just to put it again in a little perspective, 50 looks pretty different from us. That's me on the left at 50 to my great grandma at or somewhere around 50. Through evolution, through the history of the human race, what aging looks like is changing and will continue to change. So tonight we're going to talk a little bit of a historical perspective, a little bit about how you can tell if you're in menopause, and then some of the approaches that you might find helpful. So first of all, I always like to let people know that, menopause is a very modern phenomenon. Human life expectancy, as you can see there in ancient Greece and Rome, was actually quite short, 35. And even in 1905, which is a little over 100 years ago, but not too much more, life expectancy was 50. So if most of us go through menopause around the age of 50, this is a modern problem that we have. And interestingly enough, there's only 5 species that outlive their reproduction. No one is entirely sure what reproductive benefit there is to being menopausal. In killer whales, the killer whale females who have become menopausal, they'll actually help the pod fish, and they help the survival of the pod. But clearly that's not the case for humans. So menopause is probably just a byproduct of our increased life expectancy. So this is a graph of average life expectancy. This is over the entire world, and this is male and female. And it only goes up to 2017. But interestingly enough, here you can really see that we didn't hit a life expectancy that is the same as the age of menopause at 50 until after 1960, 1950, 1960. So, putting it in this perspective, women now, our life expectancy is 79 or more. And there's actually a little blip similar to the Spanish flu blip in this graph for COVID now, interestingly enough. But now we're going to live at least a third, maybe some of us up to a half of our life in menopause. So what do we do about that? You can't really treat it as abnormal or a change. I mean, it happens to all of us. And how can we adapt and continue to adapt? So it used to be, of course, called change of life, but the word menopause was coined by a French physician in 1821 to describe the time in your life where you start to run out of follicles in your ovaries. Hormones start to fluctuate. They don't necessarily plummet, but they begin to fluctuate. And it's basically a mirror phenomenon to puberty. So when young girls start to go through puberty, there are all kinds of hormonal pulsations happening in the central nervous system that are responsible for all the changes that lead to puberty. And the same thing is happening in the reverse when you go through menopause. There's a huge cultural context to it as well. Symptomatology that is the most common varies by the country. So I thought this was interesting that, of course, in the United States, the most common symptom is hot flashes. Japan, it's shoulder pain. And India, it's low vision, which, as you can tell by my glasses, and most of us have to wear reading glasses, maybe that's also for us. But the age will vary, but in general and throughout history, it has been pretty close to 50 to 51. The age at which young women start to get their first period has gotten a lot less, and it's a lot younger now. They think because of artificial light and better nutrition. We're bigger people than people were 100 or 200 years ago, and that has something to do with it. But the age of menopause has stayed very, very steady. The only difference is less developed countries where it's a little bit younger, 45 to 47, in places like India and the third world. So I thought I would also do a quick little history of HRT as well. So prior to the feminist movement, we were all considered hysterical and It was really only in the 1960s when it started to be talked about that estrogen deficiency syndrome could be treated by giving people estrogen. And so they were given estrogen alone. They even gave estrogen to men, thinking that it was going to lengthen their life, because we've always kind of known that men don't live as long as women. So they thought, okay, estrogen's the fountain of youth. We should give it to everybody. And then they started noticing that some women would get uterine cancer if they were on estrogen alone for many years. And of course, men would have all kinds of problems. So we took men off of their estrogen, and we put women on progesterone. So combined what they called at that time hormone replacement therapy, which now we kind of try not to use that term because it makes it seem as though you must replace it, like thyroid replacement. So we try to call it more just hormone therapy or estrogen therapy or estrogen progesterone therapy. So from the 60s to the 90s, hormones just got more and more popular, and they were thought to be the best thing since sliced bread. But then there was a study that was done where, because in 1988, the FDA approved Premarin, an approved hormone replacement, estrogen replacement, for the prevention of osteoporosis. So then there were all these studies that were saying, hey, we've noticed that men have heart attacks at younger ages than women do. So estrogen must be protective. We want to get an indication to give women estrogen to protect their hearts. And the FDA said, well, then you'll need to do a study, and you're going to need to prove that. So they did. They did a couple of studies, but the most famous of them and the biggest was the Women's Health Initiative, which was the largest randomized controlled trial to try to answer some of these questions. It looked at 27,000 women over a number of years, and they're continuing to reanalyze the data, in fact. And we'll talk a little bit more about some of the pros and cons of it. But it was then in 2002 that the first findings from that study were published, and it showed a possible increase in breast cancer in women who took hormones, and actually some not so good effects in terms of the heart. And so all of a sudden, all these women came off their hormones, didn't start on hormones, and hormone therapy really plummeted. But we have, again, reanalyzed a lot of the data, and there's ongoing research in the present. We'll talk a little bit more about that too. It's all very exciting. And a lot of it actually is not centering around estrogen per se, but other approaches. So we'll be talking about that. The other thing that's great is we're starting to see much more press about menopause. It used to be that women just didn't talk about it. Most of these articles that I'm showing you here are from the New York Times, and I want to call out the one at the bottom in the center. Women have been misled about menopause in particular. If you can get a copy of that, it's great. The person who wrote it really did a good job. And then even just this one on the right, I just got today, somebody forwarded me from CNN about the workplace and how much money is spent on treating, menopause, but also how much money is lost due to lost productivity because women are going through menopause and there's so many older women in the workplace. So we're going to switch gears a little bit and do a little look at all the signs and symptoms. And let me tell you, this is not an exhaustive list. So, and I'm not going to even read them all, but this was in another article I found. And I hear it all every day. This is kind of the bread and butter of my day. So there was really not much here that surprised me because I do hear it. So I thought what I might do for the purposes of trying to, have this talk before nightfall is I'll focus on kind of the most common symptoms that bother people, and we'll sort of restrict talking about just those in particular. So this is how a lot of people, think about menopause, right? It's this temporary state. I'll talk to you in 5 years when this is over. It is for some people, it isn't for others. The first and most common symptom, again, certainly in the United States, are hot flashes. And night sweats are just hot flashes at night. The other word for it is vasomotor symptoms, or VMS. So interestingly enough, the graph there on the right, they can do studies where they actually put electrodes on people's skin. So the first graph there is a woman reporting when she feels the hot flash. Then they're monitoring her heart rate, the blood flow to the skin, also when sweat is detected at the skin, and then their skin temperature. So interestingly enough, what we think happens is that your internal body temperature drops, and it doesn't drop to a great degree, but it drops enough that the brain says, oh my goodness, something's happening, and it misperceives that signal, and it thinks it needs to let go of heat. And so you sweat, your cutaneous blood vessels dilate, that brings blood to the surface so it can cool off. And as you can see, they're correlating with this person's experience of their hot flashes. Their blood flow to the skin increases, sweating increases, and their temperature increases. The good news is most of us have them at some point, either regularly or intermittently. The bad news is that it really varies as to how problematic it is, how long it goes on for. I put on average, it can be for 7 years, but I have some patients who are never really free of them. What the statistics say is that for about 25% of women, they last 5 years or less. And for about 33%, they last from 5 to 10 years. And only 8% do they last beyond 20 years. So, it's impossible in the literature to find any sort of way to predict who's going to be troubled by them, or even really know how long they'll go on for. There's no determination for sure what triggers them or explains why some people have them and other people don't. There could be a cultural context to it. For a long time, we thought that soy was good to treat hot flashes because we noticed that people in Japan had fewer of them, and a lot of Asian countries where they consume a lot of soy. And now there's a lot of research going on about our intestinal microflora. And there's something called the estrobolome, or the intestinal microflora, that somehow converts the isoflavones that are in soy to something called equal. And only some people can do that and other people can't. And that could be something genetically driven. And so maybe people in Asian, with Asian genetics are more able to convert the isoflavones into equal, and they have fewer hot flashes. Nobody really knows. But when you do functional MRIs on people who are having hot flashes, they can see in the thermoregulatory system in the brain, which involves the hypothalamus and some of these other inner brain areas, they can certainly see that something's happening in the brain while that's happening. And it doesn't seem to be, like I mentioned earlier, that it's just a drop in estrogen, because levels don't differ. Estrogen levels don't differ between people who have hot flashes and people who don't. And it's not just an absolute lack, because if that were true, then prepubertal girls would have hot flashes and they don't. So there seems to be something where it's these spikes that are happening, these erratic levels that are happening at the time of menopause in particular. Also, women on tamoxifen or certain aromatase inhibitors for breast cancer, and also, interestingly enough, men who are on hormonal treatments for prostate cancer can experience hot flashes and these vasomotor symptoms. So there's clearly something about the pulsations of the hormones. But again, There's no difference between women who are completely miserable and women who are able to tolerate how they feel at that time, and then what's happening in the brain. One thing that does seem to be true is that overweight and obese women report more of these vasomotor symptoms, and even a small reduction in weight seems to improve it. And again, there's no real knowledge about why that's true. Your environment matters. So wearing layered clothing, using a fan, stay cooler at night, drinking cool liquids, trying to avoid triggers such as hot beverages. There's no study that really proves that these types of things will set off a hot flash, but I can tell you from personal experience that absolutely these things can. Stress, alcohol, spicy foods, hot beverages, even too much caffeine, and that can trigger a hot flash. So if you know what those triggers are, you can try to avoid them as best you can. So the second really, really common, really problematic issue with menopause I wanted to talk about is vaginal atrophy. And atrophy is a terrible word. It makes it sound like something, like an illness. But also I use it because vaginal dryness alone doesn't really capture what's happening. And a lot of women will tell me, oh, it's not dry. My vagina is not dry. And it isn't all about that either. What atrophy really is, and I thought these pictures did kind of a nice job in the bottom right of the screen there, is they show you that when it's sad to use the word normal and then atrophy, but younger, when your vagina is younger, it's plush, it's cushy. There's thickness to the skin of the vagina. And that's what we lose as we lose our estrogen. On average, this happens, it can happen before you've stopped having your period, just like hot flashes. Or for most people, they don't notice it actually until probably about 2 to 3 years after they've stopped having their period. But the biggest thing is that your elasticity decreases and the vagina itself becomes shorter and narrower. And so that's why any kind of vaginal penetration can feel uncomfortable. And a lot of people are puzzled by that and also definitely troubled by it, and it creates issues in their relationships. But the good news is that estrogen really works. I tell people it's the only way that I can make you 25 again, at least in one part of your body. Estrogen was approved early on by the FDA to treat what they call the genitourinary system syndrome of menopause, which involves the vaginal atrophy, but also because the bladder's right next door, urinary frequency, frequent urinary tract infections, and issues like that that are all due to menopause. Okay, here's the other troublesome one for a lot of people, weight gain. And now again, this doesn't happen to everyone, but there is definitely a change in the body composition. And I try to comfort women and let them know that it's programmed. It's due to that time in life. And when we're younger, our bodies store fat in our breasts and our upper body, higher up here, and our hips and our thighs. And as you go through menopause, it shifts and it has more of what they call it's not gynoid, it's android fat distribution. So like a man with a spare tire, we develop a muffin top. The increase in abdominal fat is also true that around your viscera or around your internal organs, there's more fat stored there. This can create metabolic syndrome for a lot of people, which is tied to diabetes and insulin resistance. And overall, you have a loss of lean muscle mass. Part of this is from, in general, getting less active, but even really active people I mean, I've noticed myself, I can't lift the weights anymore that I used to lift at the gym when I was younger and premenopausal. My muscles simply won't develop like that anymore. It's kind of strange. And again, if it didn't happen, to me, I wouldn't even believe that it would happen, but but it does happen. Part of this again is just aging. This happens to all of us. It just really seems to be particularly noticeable at the time of menopause for most women, because this is a really, really drastic change in our hormones in our bodies, whereas in men, it's much more gradual. In general, just due to the slowdown in our metabolism, we would gain about a pound a year if you did nothing different, if you kept your diet and your exercise habits the same. Maybe there's a contribution of lack of sleep contributing to fatigue and being less active, and that's part of it as well. No one's really sure, but nobody believes me when I tell them that it's part of the menopausal transition, and all the sit-ups in the world aren't necessarily going to help, because then you just, you're still kind of thick around the middle. So I looked for some pictures of a famous face here and a famous body, because I watched the most recent Jennifer Aniston and Adam Sandler movie on the plane on my recent vacation. And she, as you can see in the picture, she's lovely, but she's thicker around the middle than she was 25 years ago. The picture on the left, that's her at some award ceremony 25 years ago, and this picture is recent. Again, she looks great, but she's definitely much more up and down, and got a little belly. So if it happens to Jennifer Aniston, it can happen to us too.
I love it.
So in general, I try to encourage everyone to exercise regularly. These are still always your go-to measures for dealing with the weight gain. So I put the numbers up there. I don't have to read them to you, but those are now the established goals for the US in terms of what to encourage people to do. And overall, if you could reduce your caloric intake 500 to 750 calories a day, you would have a nice steady weight loss of 1 to 2 pounds a week. And then, interestingly enough, in the Women's Health Initiative, they did report that for women on hormones, their BMI, waist circumference, fasting insulin, and glucose levels were lower than women who were not. So for what that's worth, there's certainly no studies that show that hormones help. And in fact, there was a great study they did with monkeys, one of our closer relatives than killer whales. And they took, monkeys, divided them into 3 sets, and they took the ovaries out of all the monkeys. So they basically put all the monkeys into menopause. And they gave one group placebo, they gave the second group estrogen alone, they gave the third group estrogen and progesterone. All the monkeys gained weight. And the monkeys who gained the most weight were actually the monkeys that were on the placebo. So, maybe there is some benefit there. And again, even if you're sleeping better, that's been tied to, being more successful at weight loss efforts as well. So there could be a component of that. And then my esteemed colleague, Dr. DiFiore, is going to talk much, much more about your bone health in a few weeks. But I thought I would just go over a couple of points about osteoporosis as well, since this is a really common thing that women ask me about taking hormones and whether it's helpful. So the graph that I'm showing you there is important, because the top line is males and what happens to their bone density. And as you can see, all of us peak at about 30. So depending on how much calcium and what your diet's been like and your exercise habits, but more so your diet as a younger person, the dotted line there is a person who hasn't had has had a suboptimal lifestyle in terms of dietary calcium intake over their life. So they never reached the peak bone density, perhaps, that a person who had, better dietary intake had. But you see how the male slope of the curve is just gradual the whole way down from 30. And you see what happens to women. The dash
Looks like Dr. Jackson's frozen.
Oh yeah, it looks like Dr. Jackson's computer just bombed. Let's see here. If everyone could just hang tight, she'll probably be logging in momentarily.
Okie doke.
I'll go ahead and text her. She'll probably just log in right now. Thank you.
You can take this time to write your questions in the Q&A, right?
Oh, where did I lose you guys?
The graph on bone loss. He was just going through the men's gradual slope and
Excellent.
yeah.
There you
Excellent.
go. I'll let you go ahead and
Excellent.
take over my screen share.
All right. Sorry about that. Somebody
no
killed
worries, it happens.
somebody killed my internet.
Mhm.
All right, here we are. Okay. So when it comes to how much estrogen is good to take to try to help with this, they've studied many different dosages, but it seems to be that a minimum of 0.5 milligrams per day of oral estrogen or 25 micrograms per day in a patch. There is a lower dose patch that's also been approved for prevention of osteoporosis, but it doesn't seem to do it quite as robustly as these doses. The unfortunate piece of news is that you still will lose bone within about a year of stopping the hormones. And, so the current recommendation is that if you're going to do hormone replacement therapy for the benefit of your bones and to try to prevent osteoporosis, the best time to do it is right around menopause. So, within the first year that you start not, having your period, and maybe continue for just a few years. And then after that to go off because you probably have derived the best benefit from it that you could. But again, I'm going to defer to Dr. DiFiore because I'm sure she'll talk a lot about it. And again, this is not for the treatment of osteoporosis, but rather the prevention. Okay, now why is that not working?
Click your cursor on the screen and then just go ahead and hit one of the arrows.
Okay.
Right, there you go.
There we go. That worked. So hormones. Main one is estrogen. Estrogen is really the business hormone that does most of what we want it to do. It helps with most of the physical symptoms. And according to the North American Menopause Society and pretty much everyone, hormone replacement therapy is the #1 treatment for hot flashes, the symptoms of menopause. They used to say they wanted us to have people on the lowest effective dose for the shortest amount of time. And now they've revised that statement as of last year to say that the benefits outweigh the risks in the first 10 years of menopause for vasomotor symptoms and to prevent osteoporosis. So they've the pendulum swings, as it always has. There was all this enthusiasm for hormone replacement therapy, then oh my goodness, it's terrible, and now we're back to a little more enthusiasm, but not indefinitely. That there's probably a window when it's beneficial. So in terms of the ways that you can get systemic estrogen, there's oral pills, there's transdermal, which consists of patches or gel or a spray that sort of, works like, deodorant. It evaporates on the skin. And then there's also vaginal rings that are actually designed to give you systemic levels of estrogen. These are different than treating just vaginal atrophy. For that, there's estrogen cream, estradiol cream, Premarin cream. There are little tiny dissolving pills, or effervescent as they call them. I like that. And then there's also a ring called E-string. There's also an oral pill called Osphena, which is not estrogen, but it's an estrogen receptor modulator. So it's like what they call a designer estrogen. And taking that oral pill can actually just have estrogen-like effects in the vagina, but none of the estrogen-like effects in the breast or some of the other parts of the body that we don't want. So again, this is a total overview, but estrogen is really the one hormone that tends to resolve the issues that are the most troublesome. Helps with sleep. Now, progesterone, you need to offset the risk of uterine cancer. So anybody who has not had a hysterectomy should be on progesterone. There are natural and synthetic forms, and the natural form in particular can really help with sleep. So for most women who are initiating hormone replacement therapy, and this can be started whenever the symptoms are troublesome. So this can be started in a woman who's still having a period. It can be started within those first couple of years of not having a period. We just don't start it, say, after age 60 or 70 to help with these things when somebody's had their menopause already in their 50s. Oral is really the only form that's approved to balance out the effects of the estrogen. I do have a lot of patients who can't tolerate oral progesterone, and so there are vaginal forms of progesterone that can be used. There's also progesterone cream that a lot of people have talked about, but in particular, progesterone is a really big molecule, and so it isn't absorbed well through the skin. And that's the reason why we don't use it to offset the effects of the estrogen, which is a small molecule and can be absorbed really readily through your skin. Progesterone is all over the map when they try to study it to see whether you're getting enough to balance the estrogen. And so that's why we don't tend to use it as much. It's kind of more of an off-label use. Similarly is putting in a progesterone containing IUD into the uterus, which I have several patients who do that. We put a little progesterone IUD inside their uterus, and then they don't have to worry about taking progesterone. And certainly it's not there for birth control. It's there for, offsetting the estrogen effects. Testosterone. I get a lot of questions about testosterone, and there's no FDA approved form for women. There was a pill called Estratest, which is harder and harder and harder to come by in this day and age. As you can see from that little chart on the right, which is super tiny, but the main point of it was that there's a hormone metabolism system in the body. And so hormones start in a certain form, and then they cascade down into other forms. And testosterone actually gets converted into estrogen. And so Estratest was developed it's a combination of Premarin plus a tiny little bit of testosterone. And it was developed for people who had refractory hot flashes on Premarin alone. It was never really developed to be used the way that we use testosterone cream now, to help in particular with libido. And it helps, you generally will apply it in the genital area, so it can help with clitoral erection a little bit and sexual function. It definitely, when it's been studied, it seems to work better when you use topical estrogen in the genital area as well. And there are several compounding pharmacies that can compound it into a cream in the area. It's one of those hormones that, you know, you don't produce anymore when you don't ovulate. The number one time when you're younger and you produce testosterone is at ovulation. And that's why it's so important for libido. And that's why so many women on birth control pills have no libido, because they don't get that burst of testosterone mid-cycle. You know, our bodies are always trying to, you know, follow their reproductive destiny. And like we talked about at the beginning, when you go through menopause, you no longer have a reproductive destiny. So it's very normal for your testosterone levels to fall and to maybe need a little boost from it. Downsides of it are that it can cause acne, and it can definitely cause unwanted hair growth for a lot of people. They don't like that. Makes your skin a little bit oilier. It can also make you a little bit aggressive. And so I actually had a patient once who I gave it to, and she said, "Oh, you know, that stuff's great. I just, you know, I put it on and then I chase my husband around the house. I'm just not sure when I catch him if I want to have sex with him or kill him." So there's definitely a fine line you have to walk there in terms of libido and energy, and then, you know, getting a little aggressive. DHEA is it's primarily a supplement. If you search it, the thought was, again, going back to that little hormone diagram, that if you give people DHEA, that the downstream effects will turn into the hormones they need, like estrogen. And it's never really been proven to make that much of a difference. It's definitely been proven in the vaginal area to help. There's a product now called Intra Rosa. You can also get compounded suppositories, which help a lot. You just have to use them every day. Estrogen cream or estrogen tablets, you can get away with using 2 or 3 nights a week. But the DHEA, you would need to insert every single day. And then again, you get the androgenic side effects, like with the testosterone, where you might get acne or hair growth, and that's not very desirable. So DHEA doesn't tend to be part of sort of standard systemic hormone replacement therapy. It's kind of more of a supplement thing. So I thought I would kind of go through some non-hormonal therapies too. And I went and I looked through a lot of the different studies. There are things about paced breathing exercises. What else? Yoga, meditation, acupuncture, and, you know, data's conflicting. There was one study that showed that these paced breathing exercises could help. Cognitive behavioral therapy supposedly can help. Hypnosis can help, but nothing really all that predictable. Clonidine is a really old medication that actually usually comes as a patch. It's a transdermal patch, and it does reduce hot flashes, but it has a lot of side effects. And again, the studies are pretty conflicting, so we don't tend to use that very much. A common medication we do use a lot are some of the what they call SSRIs or SNRIs, or serotonin and norepinephrine reuptake inhibitors. So they're medications that are commonly called antidepressants, But in very low doses, a fraction of what we use for antidepressant use, it actually has been shown to help with hot flashes because, again, the majority of the research now is on the brain and looking at neurotransmitters in the brain. And these do seem to be affected. So very, very helpful for some people. As I put there, though, there are conflicting studies, and the reduction in hot flashes may only be on the order of maybe 1 per day, which if you're having 10, maybe isn't all that helpful. The other big limitation is that, most of the women who would have to take these kinds of medications are women who couldn't take estrogen, like women with breast cancer. And as it turns out, you can't take paroxetine and fluoxetine with tamoxifen because it actually changes the metabolism of the tamoxifen, alters the levels of it. So you're not supposed to take those together. So that definitely limits its use. It also can take quite a while. The studies were saying it takes 2 weeks to see an effect, but I've certainly seen patients take 6 to 8 weeks to see any effect of being on those medications. Gabapentin, similarly, is a central nervous system drug that's used it's an anticonvulsant, but it also can reduce hot flashes. It has a lot of side effects as well, and especially in the kind of doses that you might need to see the reduction in hot flashes. Some studies said that you might see it even at 100 milligrams before bedtime. It might help with sleep and night sweats. Other studies said you could go up to 2,400 milligrams a day, which, I would probably be a zombie at that amount of gabapentin. Many studies have been done on red clover, black cohosh, soy, and not a single one of them has really shown a significant difference compared to placebo. So plenty of patients will use them, and I encourage them to, because it can help some people. And why not, but studies don't necessarily support that any of those are any benefit. The new very exciting one is on May the 13th. They just approved this new medication, Veozah. And what that is it's now FDA approved to treat hot flashes and vasomotor symptoms. It's a neurokinin 3 receptor antagonist. So it is a central nervous system medication that seems to affect the temperature control center in the brain and can reduce hot flashes by 63%. So still number one is hormones, estrogen, some of the neurotransmitters, the norepinephrine and serotonin drugs help, but less so. And then this one is probably in the same neighborhood. So more exciting research probably to come there. And I haven't had a chance to start anybody on it because, of course, it's only a few days, weeks on the market. It also has a lot of side effects, abdominal pain, diarrhea, things like that, gastrointestinal side effects. But clearly it doesn't have side effects like hormones can, or, could be a drug really, really helpful for women who can't take hormones. So in conclusion, I just wanted to reiterate that, menopause is certainly normal, byproduct of our extended lifespan. And it's very disruptive for a lot of people. For other people, it's not, and there's no judgment there. It's just what, the hand we're dealt. And I just try to encourage women to continue to be creative. Maybe you're not reproductively creative anymore. You're not building your family anymore, but you have many, many other ways to be creative and contribute to the world. A lot of research has been done. And again, I feel it myself, being almost 60, that, you start to feel a little bit invisible. And it doesn't have to be that way. I think we can all be fabulous every day. So your experience of it is your own. There's no right answer for everyone. And whether you use hormones or one of the alternatives, or you just kind of muscle through, you can thrive. The goal is healthy aging through diet and exercise and healthy habits that reduce your risk of cancer and cardiovascular disease. And cardiovascular disease is the thing that's going to, most women don't realize that cardiovascular disease is the number one leading cause of death in women. So doing things that keep you healthy and reduce your risk of those diseases is the most important thing. So with that, I will stop sharing and take any questions.
Thank you so much, Dr. Jackson. Well, we have a lot to look forward to. I did want to add that I just read today in CNN, they announced the drug, the non-hormonal drug, Veoza. So if anyone wants to go to CNN under their health section, there should be an article about that today. So with that said, we do have some questions here. Let me go ahead and get to the first one. The first question is, what do you recommend for pain, dryness during intercourse for someone who is 7 years postmenopausal?
Estrogen cream or tablets. That's going to help with the elasticity. And then, of course, lubrication. Lubrication is key. And then the third part is, of course, regular usage. So what ends up happening is for a lot of people, they don't have intercourse often, and then it gets less and less often because every time you do it, it's more and more painful. So some women will actually help dilate their tissues, dilate the vagina a little bit. So it's a 3-part approach of estrogen of some kind and lubrication, really good water-based lubrication, and then mechanical dilation, either regular penetration or either through sex or through some other method. And it's very successful. You can be successful.
Thank you. Will hormone therapy work if you don't start it until many years after your last period?
That's the crux of the issue. Work, right? So for vaginal atrophy, absolutely it will work. You could be 70, 80 years old and go for it, and it can make a difference. But once you've passed the age of 60, a lot of the menopausal symptoms have kind of calmed down. It's really it's a transition time in our lives. And so that's where hormones are the most helpful. And again, they're really helpful when it comes to hot flashes and night sweats. A lot of people tell me about brain fog. And so I did some research there. And it's actually interesting. They've shown that people who have a lot of night sweats, a lot of disruption of their sleep, do have some cognitive impairment when it comes to verbal recall. Depression, again, I hear it a lot from people, but no study has actually shown that estrogen necessarily helps. But again, if it's going to help you sleep and it's going to kind of sort out a lot of the other craziness that's going on at the transition time in your life, then, it can only help your mood as well. But, if enough years go by, it kind of depends on what the, symptom of menopause is. Is it depression? Is it brain fog? Is it dementia? Is it what exactly is it you're looking to address? And there may be a role for estrogen if it's just vaginal atrophy, but systemic estrogen, probably not.
Okay, thank you. Next question. If a woman has antiphospholipid syndrome, is the E-string or topical estrogen cream for vaginal atrophy and dryness safe to use?
Absolutely. They've studied topical estrogen for women with all kinds of contraindications to hormones, systemic hormones, so birth control pills or estrogen pills or estrogen patches. But vaginal estrogen is so low dose, it's been studied in women with breast cancer and does not cause recurrence of breast cancer and does not lead to any systemic levels that are concerning in any way. So yeah, somebody with antiphospholipid syndrome, even somebody that's had a prior pulmonary embolism or a DVT, should be able to use topical estrogen.
Okay.
Yeah.
Next question. Can somebody take Osafina while on estrogen patch and progesterone?
That's a good question. I suppose you could. I don't know. I'd have to look up and see if it's actually been studied. I know they haven't studied it in women with breast cancer, so they don't recommend Osfina in women with breast cancer. But it seems to me that if a person just wants to avoid any kind of vaginal application of something, that perhaps there's a role for it there. But I would have to look that one up. You've stumped me.
Okay, next question. Would you recommend hormone therapy to someone now going through menopause that has had breast cancer?
Again, part of it is working in conjunction with your oncologist. So if you're looking to use systemic hormones, it's generally frowned upon. I do know of some patients, I have some patients who had breast cancer 20 years ago. They're on very low doses, and it just helps their quality of life. And they do all their regular checkups. They get their mammograms or their breast MRIs, and there's no data out there in terms of systemic hormones and women with breast cancer. Certainly not right away, but after a certain period of time, it's kind of an interesting question. Verboten thing. So.
She might need to log out and log back in.
No, it just gave me a
Oh,
message
there
and
you are.
said my internet was unstable. Good thing I'm not. Not too
Okay.
much anyway.
We just have a few more questions. So I didn't know if you wanted to, was regarding breast cancer. That's right.
Yeah.
Coincide.
I don't know where it cut me off, but in general, we don't give systemic hormones to women with breast cancer, even if it's been many, many years. But I do have some patients who are on it where it's been 10 years or 20 years since they had their breast cancer, and they feel better when they're on a very tiny dose. But again, if you kind of look at what the North American Menopause Society says, their party line is no hormones, no systemic hormones. Vaginal's okay, but no systemic hormones for women who have had breast cancer, have had a history of breast cancer, and certainly not if you're being treated for breast cancer.
Thank you. Just a couple more questions. Has anything changed in the use of systemic estrogen for people with a history of DVT, even if it was a provoked DVT over 20 years ago with no subsequent problems?
No, once again, that's one of the ones where it's on the list of contraindications. But I do have some patients who just, with really good shared decision making, we come to a decision that feels best, and they do some sort of low dose hormone therapy, because it's just considered one of the contraindications to systemic hormones.
Okay, a couple more. Is it possible to go through menopause without any symptoms?
Yes,
That would be awesome.
Yes. I do know a couple women where they tell me, oh, I just didn't have my period anymore one day.
Okay, I'm a 49-year-old female. I've been taking the ring birth control due to severe cramping. Will I stop bleeding naturally going through menopause? And when do you recommend getting on hormone replacement therapy?
Anybody who's using any kind of, whether it's a ring or birth control pills that's giving you a cycle, you could continue that indefinitely and you will always have a cycle, because it's those hormones driving the growth of the lining in the uterus and then shedding it. So you're not going to be able to tell when you go through menopause. So what we do for most people is try to protect them against pregnancy if they're at risk for pregnancy. We try to protect them through the age of 50, 51. And then we do a test of FSH, which is a hormone that comes from the hypothalamus that drives the ovary and communicates with the ovary. You can do a test of that during your hormone-free interval with your ring or your pills to see if your body's going through menopause, to kind of see if that level of that hormone is elevated or not, and if it's time to switch over to hormone replacement. That's what we do for most people.
Okay. And then one last question is, I just have a quick question. Me, personally, I have a friend that's doing the BioT synthetic pellet therapy. Do you have any thoughts on pellet therapy, negative, positive, with the synthetic hormones?
I'm glad you brought that up. So the one thing I didn't mention was that buzzword of bioidentical, which has certainly been talked about quite a bit and sort of put out there as though it's somehow safer or different than the commercially available preparations. And really it's kind of just a buzzword. I like to use the word bioequivalent. So when I prescribe 17 beta estradiol in a patch to somebody, that's exactly what your ovary used to produce. So that's bioequivalent. It comes from plants, so you don't have to necessarily simulate a menstrual cycle anymore. And you don't have to slather creams and get compounded medications or have any sort of blood or saliva testing. Because again, back to the point I made earlier, there's no levels that say you're going to have hot flashes and problems and levels that say you're not. So there's no point checking any levels because they aren't supposed to be anything. They are what they are. So, but when it comes to things like the pellets, the absorption is just variable, so those things just disintegrate. You don't have to have them removed. They get injected under your skin and they release tiny amounts of testosterone over time. So that little bit, the only issue I have with it is that once it's in you, you can't control it. It's not like something you're applying to yourself. So if it's something where it's going to make hair grow in places you don't like or give you acne, you can't really do anything about it until it wears off. And again, there's no real established levels like your testosterone should be this or your estrogen should be that. It's all based on how you feel, and that's how we dose what you end up getting. But I much prefer the ability to use a patch that has an amount that you're getting this amount, and then you can take a lower patch or a higher patch or a cream that you apply X amount of, that's a certain percentage, so that you can adjust it. Because if you don't like the effects or you want more, you want less, you can't change it.
Good points. Yeah, thank you for that. All right. Well, I think that pretty much ends all the questions that we have, and we are about at time at 6:35. So I just wanted to bring everyone's attention to, thank you so much, Dr. Jackson. We really appreciate your expertise and your time this evening. And these are just a few things that we have coming up here. Our next one is Building Your Bone Health, which is great because it coincides with Dr. Jackson's talk on June 28th with our rheumatologist, Dr. DiFiore. And she will be talking about how to prevent osteoporosis and building your bone health. And then upcoming next week on Tuesday, June 13th, in person at our Wellness Center on East Cliff Drive, we are having a oncology health fair. So please do contact just one moment here. Let me get to the next page. Sorry. Contact our Dominican Wellness Center at 457-7099, or you can register online at dignityhealth.org/Dominican/PEP. If you have any issues registering for these free classes or health fair or webinar, then you can just call the Wellness Center and they can do it for you. So thank you everybody for attending our educational session. Thank you so much, Dr. Jackson. Be well. Have a good night. Get some sleep. Thank you, everyone. Bye.
Thanks, Sandra. That was great.
Thank you. I'm just gonna go ahead and go out. Thank you, guys. I don't know how to stop the recording, so I'm just gonna say goodnight.
Good night. Thank you.
Bye, everyone.
Bye.